So with that, I'm going to introduce Dr. Elaine Wirrell, who is the Director of Pediatric Epilepsy at Mayo Clinic, who's going to talk to us about the clinical features of LGS. So if you can share your screen, and thank you again for being here.
Well, thank you very much to Anne, Heather, and Tracy. I certainly share your enthusiasm about this meeting. I'm very excited to be part of that, and thank you very much. So I'm going to kick this off really by talking a little bit about the history of LGS, the clinical features, and the EEG findings. So the overview here is to provide a brief review of the history of LGS. I'm going to spend most of my time on how we diagnose LGS, really what are the core clinical and EEG features, and talk a little bit about how these evolve over time, because I think sometimes our adult neurology colleagues have a bit of a more challenging time making this diagnosis if we have not made that diagnosis in childhood. And then we'll talk a little bit about distinguishing LGS from other early onset DEEs. Not all early onset DEEs are LGS. Some of them clearly will evolve to that, but how do we distinguish some of the important differentials? So first of all, we'll start with the history of Lennox-Gastaut, and here is Dr. Gastaut. So looking at the early history, I think it was recognized very early on that there were specific seizure types that were recognized to have a very poor prognosis. And these included atypical absences, tonic seizures, and atonic seizures. So, our colleagues before us really recognized when they saw children with these types of seizures that was a very bad sign. Gibbs and Gibbs in 1938 published this paper on the EEG finding of Lennox-Gastaut, the slow 2 Hz spike wave, and called it the Petit-Mal variant, and really recognized that it was very different than the typical 3 Hz generalized spike wave that we see with childhood absence epilepsy. So this was back in 1938. And then in 1950, William Lennox looked at the clinical correlates of the fast and the slow spike wave EEG. And what he noted was a greater variety of seizure types with the slow spike wave, the atypical absences, the drop seizures, the myoclonic jerks. He found or reported evidence of intellectual disability or evidence of what he called brain damage that precedes seizure onset. He noted that these children present at a younger age than those with typical childhood absence epilepsy, and that they had a greater number of other associated EEG abnormalities, so multifocal discharges, generalized paroxysmal fast wave, et cetera. And then Dr. Gastaut was really the one that kind of brought this all together and sort of described the characteristic triad of LGS that we all recognize today. And this was in 1966, this publication. And he noted sort of the 3 features of the triad: the frequent tonic seizures and often atypical absences, the associated intellectual disability, and then the EEG picture of the diffuse slow spike wave. So that was really recognized back in 1966 as the characteristic triad. So we'll move on to diagnosing Lennox-Gastaut syndrome. So I have been working for the last 4 years on the ILAE Nosology and Definitions Committee, and we are looking at all of the epilepsy syndromes and proposing definitions for each of those. And for each of those definitions, we are proposing core features as well as some red flags or atypical features that should suggest, looking at an alternative diagnosis. So as far as the core features for Lennox-Gastaut, so there's clinical features. And you must have tonic seizures as one of your seizure types, plus at least one other seizure type. And many patients with LGS, as Tracy had already mentioned, have numerous other seizure types. Probably the most common second type is atypical absences, but myoclonic, atonic, generalized tonic-clonic, focal seizures, spasms can all be seen. So you have tonic seizures plus at least one other seizure type. The epilepsy is drug resistant. And long-term, it is associated with mild to profound intellectual disability, often with more significant disability later in life. And it onsets typically before 18 years, and in fact, usually before 10 years. The EEG has two characteristic features, but it's important to recognize that those features may not be seen all the way through life. And so the first is generalized slow spike wave, and that's the one that sometimes we no longer see in adulthood. And then the second one, very important, is generalized paroxysmal fast activity in sleep. And I think this can be a helpful one to look at early on if you are wondering if that child is really moving towards Lennox-Gastaut or has Lennox-Gastaut. This was an important study that was done by Ann Berg looking at her Connecticut cohort, and I think really speaks to the fact that when people present with LGS, that's not something that they develop one day and have. It's something that tends to evolve over time, and it often evolves from other early onset DEEs. So what Anne found is that it accounted for about 1% to 2% of all epilepsies and about 13% of all infantile onset epilepsies, and usually evolved from another early onset epilepsy. And you can see here the initial diagnosis. Only 4 of these individuals had Lennox-Gastaut. In fact, West syndrome was certainly the most common DEE that was seen. But then by the end of follow-up, Lennox-Gastaut was actually the most common diagnosis. So many of these other DEEs can evolve to Lennox-Gastaut syndrome. And she found that the evolution to Lennox-Gastaut takes a median of 1.9 years to evolve. So again, this is something that we see a process over time, and I think others today have clearly commented on that. So looking at the epidemiology, we know that for most children, the peak age at diagnosis is between 3 and 5 years. You can have diagnoses after the second decade, but that is pretty uncommon. And some of my colleagues at Mayo Clinic described a small cohort of patients with late onset Lennox-Gastaut syndrome. Other clinical features at presentation. So looking at the neurologic examination, one can certainly find abnormal findings on the neurologic examination, but that is not really part of the core diagnoses of LGS, but really more reflective of the underlying cause. And we know that most children will have preceding developmental impairment, but not all. So some of them, like Tracy's daughter, did not have clear developmental impairment before seizure onset. However, when they start developing the very frequent seizures, we often see sort of a stagnation or even potential decline in their development. So looking at the seizure types, I wanted to go through those. So first of all, tonic seizures. These are really mandatory, and here's a good example of a child with Lennox-Gastaut and tonic seizures. You can see here the sustained increase in axial and limb tone. These generally last at least 3 seconds up to several minutes, and they're distinguished from infantile spasms because they last typically longer, and they often, or they have a less frequency to cluster. These are often more prominent in sleep, and if they occur in sleep, they can be very subtle. So you may just see this subtle upward eye deviation and a little bit of shoulder extension and neck extension. If they occur while the child is awake and upright, they can certainly lead to a fall. Another characteristic seizure type are atypical absences. And these are distinguished from typical absences in that they have a much less clear onset and offset. The child is often having clusters of these and just looks more in a fog. You can see this girl here who has her phone, and she'll have more frequent periods of the generalized spike wave of absence. When that settles down, she'll go back and play on her phone a little bit, and then we'll come back and have another absence. Here you can see she's playing on her phone. And these occur in the majority of cases. One of the more concerning seizure types, just because of the risk of injury, is the atonic seizure. And these occur very, very abruptly, really no warning at all. There is an abrupt loss of axial tone with a head nod or a sudden fall. These do occur in the majority of persons with Lennox-Gastaut syndrome, but are often a bit more prominent in childhood than in adulthood. Here's an example of a patient in a sling, and you can see what would happen if they didn't have. They just lose tone.
That's what she does. We need to push a button.
Result in multiple injuries to And then myoclonic seizures. Myoclonic seizures are brief, irregular twitches. Again, they can lead to a fall if they occur when the child is upright, so it can result in a drop. And these are seen in at least a quarter of patients with Lennox-Gastaut syndrome. Here you see some myoclonic jerks in this patient. And then epileptic spasms can occur, as we had noted. It is not uncommon for individuals with West syndrome or infantile spasms to evolve towards Lennox-Gastaut. These consist of clusters of brief flexor or extensor or sometimes mixed movements. These are more commonly seen and persisting in those who evolve from West syndrome. Other seizure types can also include generalized tonic-clonic seizures or focal seizures, both of which can be more common later in the course. And then another important feature for Lennox-Gastaut is non-convulsive status epilepticus, and that is very, very frequent. It occurs in at least half to 3/4 of cases and can often be a bit challenging to recognize in a timely manner. Particularly, these patients are often having, frequent seizures anyways. They have intellectual disability. And so I think here we really want to be sure that we listen to the parents. The parents will often come in and say, you know what, my child is just not right. They really seem more out of it. They really seem much more in a fog. So here is the EEG feature. So we see this generalized slow spike wave, not super well organized, sort of 2.5 hertz at best. And then we see this generalized paroxysmal fast activity. This is a pattern that we typically see in sleep, and this can often be associated with subtle tonic seizures, but not always. So other investigations that can be done, neuroimaging can be normal, but it can show a structural abnormality. It really depends on the underlying cause of the Lennox-Gastaut syndrome. And then genetic investigations can also show a causal gene, and I will leave that to Dr. Patel to discuss in further detail. So looking at how Lennox-Gastaut evolves over time, and I think here is, we need to be paying attention to this because I think this is something that can be a little bit more challenging to definitively make this diagnosis in adulthood. So over time, we often see the number and variety of seizure types decrease with time. However, most patients continue to have very frequent seizures despite that. It's not that the seizures go away. The daytime seizures often reduce more significantly. The nocturnal tonic seizures usually persist, but again, can be quite subtle. And so it may not be recognized unless somebody is actually watching the person sleep or sleeping in the same room. And then over time, focal seizures as well as generalized tonic-clonic seizures can become more prominent. Non-convulsive status epilepticus usually reduces with time, but can be a risk at any age. This is work from Ferlazzo, and they looked at what happens long-term in persons with Lennox-Gastaut syndrome. So you can see here tonic seizures during wakefulness in yellow and during sleep in purple. And at the onset, we see that essentially all of these patients have tonic seizures both during wakefulness and sleep. But at last follow-up into adulthood, we see that the number with tonic seizures during wakefulness has markedly reduced. But again, these still persist in sleep. And then looking at other seizure types, in blue are the seizure types that were present at onset, and then in red at last follow-up, we see the atonic seizures reducing with time. We see atypical absence seizures reducing with time. The generalized tonic-clonic seizures persist. The myoclonic seizures reduce. The focal seizures actually become more frequent. And again, the non-convulsive status epilepticus reduces, but does not completely, in my experience, go away in adulthood. And then how does the EEG evolve over time? So oftentimes, in addition to the seizures seeming to reduce somewhat in number, we see a reduction in the amount of seizure discharge, at least on the awake EEG. The generalized slow spike wave often does decrease with time. And in fact, it can even be absent in teens and adults. And so that can be a problem if we have drug studies or therapy studies that require the presence of this. It may only be seen historically. The generalized paroxysmal fast activity does persist in most cases, but you often need to record sleep to see that. And then over time, we tend to see more multifocal independent spikes increasing with age. And then here is from the Ferlazzo study looking at the change in EEG. So first of all, the slow spike wave at onset, we can see it present in the majority of patients. And then you can see the last follow-up, the number with slow spike wave in the blue here is much decreased. The fast recruiting rhythm is frequent at onset, and it still is very, very frequent at follow-up. So that fast, generalized paroxysmal fast activity or recruiting rhythm does tend to persist. And then looking at intellectual ability over time. So over time, we often see worsening in developmental impairment. After 5 years from the onset, about 95% will have variable degrees of intellectual disability. It has been shown that persons with Lennox-Gastaut, 80% have a decline in their IQ by greater than 15 points with time. And by adulthood, most are left with moderate to severe degrees of intellectual disability. So we can see here as those seizures become more frequent, the development really does have a significant impact. And then looking at what are the risk features for intellectual disability and the degree of intellectual disability. So persons with earlier age at onset, those who have had prior West syndrome, known causes and specific causes, particularly some of the genetic causes or structural causes. And then it is felt that more frequent or prolonged non-convulsive status epilepticus also does have a cognitive cost. Looking at behavior problems, this is often a very significant problem, particularly in adolescence and adulthood. Oftentimes we see worsening behavior in adolescence when we are seeing significant physical, mental, emotional, and social change as well. And many of these individuals have problems with hyperactivity, with aggression, with autistic traits. And this can be very, very challenging for caregivers and families. Other mental health issues like anxiety or depression can also further exacerbate these behaviors. And so it's really important to have in your armamentarium of health professionals somebody with expertise in mental health in looking at children with developmental disabilities. Other issues that can be seen, sleep deprivation or sleep disruption is often a common problem. This can be exacerbated by nocturnal seizures and can also lead to excessive daytime sleepiness that can be exacerbated further by medications. Looking at gait, deterioration in gait is seen in between 15 and 20% of persons with Lennox-Gastaut syndrome, and some individuals end up being wheelchair bound by the time they hit adulthood. And then feeding problems can also increase with time, particularly in individuals with higher seizure frequency who are having very frequent atypical absence seizures. So I just wanted to briefly end with a discussion on how this is different than other DEEs. And I think when you are seeing a young child with DEE, it's a bit challenging. So first of all, there's lots of rare conditions that can lead to these DEEs, but also we know that this is a bit of a moving target, that oftentimes these DEEs evolve with time to other syndromes. So it is important that we pay particular attention to seizure types, to the EEG features, and then to the child's development and other medical problems. Again, we had mentioned that this is more challenging in adults. If we do not have a clear early history, some of the core features of Lennox-Gastaut syndrome, as well as some of the other core features of other DEEs, may no longer be present. And so it's, I think, a little bit more challenging for our adult epilepsy colleagues. So a brief word on infantile spasms syndrome. We know that between 20 and 33% of cases of Lennox-Gastaut actually evolve in children who have preceded or who have been diagnosed previously with infantile spasm syndrome, which is going to be the new term for West syndrome. And what does infantile spasms syndrome comprise of? So typically it begins before 2 years of age, usually less than a year, clusters of tonic spasms. And those spasms last generally less than 2 to 3 seconds each and occur in clusters. The EEG is abnormal often, but not always, showing a hypsarrhythmia pattern. But generally, when you're having the infantile spasms at the time of your diagnosis, you do not have the slow spike wave or generalized paroxysmal fast activity. Another one that we want to think about is early infantile DEE. This is formally termed Ohtahara syndrome or early myoclonic encephalopathy. This syndrome begins in the first 3 months of life with multiple seizure types, including tonic seizures, myoclonic seizures, spasms, sequential seizures. Sequential seizures are seizures that kind of move from one semiology to another semiology. And I'll show you here on the video, this is a child who has at times a tonic component, at times a myoclonic component, at times a clonic component. These individuals have severe to profound developmental delay. The EEG usually shows a suppression burst pattern, but may also show multifocal discharges, often superimposed on a high amplitude background. And these cases may also evolve to Lennox-Gastaut syndrome with time. So here's a little baby with early infantile DEE, evolution of technology as the seizure goes on. Get eye deviation over to the right. Tonic cluster, eye deviation to the left. Tonic component. And then ultimately you'll see the clonic component as well. And then Dravet syndrome. Dravet syndrome begins in the first year of life with prolonged hemiconvulsive seizures, typically triggered by hyperthermia associated with an SCN1A pathogenic loss of function variant. This does not evolve to Lennox-Gastaut. These are quite distinct syndromes. And then I think the one that is most commonly misdiagnosed as Lennox-Gastaut is myoclonic atonic epilepsy or DUCE syndrome. These children are typically normal before seizure onset, and so that's a little bit of a red flag. You can have that in persons with Lennox-Gastaut, but that's a little less common. The characteristic seizure type here is a myoclonic atonic, so there's a jerk and then a drop, as opposed to just a drop. And oftentimes with that jerk, you'll have a little bit of a vocalization. There's a strong genetic component here, so other family members may have other types of generalized epilepsies more commonly. The EEG tends to show these monomorphic biparietal theta rhythms as well as generalized spike wave. And you can see generalized paroxysmal fast activity in some cases, but that is much less common and it is usually seen later in the course. And it's important to recognize myoclonic atonic epilepsy because overall, while these kids can have a pretty challenging initial time with their seizures, long-term about 2/3 of them do well. Many of them will actually outgrow their epilepsy. And then about 1/3 of them will do poorly. They don't do as poorly generally as kids with Lennox-Gastaut, but they can be quite sick with their seizures. So here you'll see some myoclonic component, and then a bit of an atonic component, and a child with myoclonic atonic epilepsy. These kids can respond very nicely to the ketogenic diet. And then sometimes what gets miscalled as Lennox-Gastaut is what is now termed developmental and epileptic encephalopathy with spike wave activation and sleep. It has been known by many other names, such as continuous spike wave and sleep, Landau-Kleffner syndrome, pseudo-Lennox syndrome, atypical benign focal epilepsy, but it is now going to be under one name, and this is the name. These children have cognitive, behavioral, and or motor regression in conjunction with an EEG that shows marked activation of discharges in sleep. And so here's an example where you have a patient during wakefulness and you don't see very much, but during sleep, you see essentially continuous spike wave. And if you just looked at that sleep recording, you might say, oh, that looks like a diffuse generalized slow spike wave pattern. But what makes this different is it really is not there during wakefulness. So this is a marked activation in sleep. And we know when we see this, we really need to treat focused on trying to resolve this very abnormal EEG pattern, typically with high-dose steroid or high-dose benzodiazepines, in order to afford developmental improvement. So in Lennox-Gastaut, you see this slow spike wave both in wakefulness and sleep, and also you see this generalized paroxysmal fast activity in sleep, which is not seen with DEE with spike wave activation in sleep. And then frontal lobe epilepsy can occasionally be miscalled as Lennox-Gastaut. So these patients can present with asymmetric tonic seizures, and that's the clues that they're asymmetric because oftentimes frontal lobe discharge can be seen bisynchronously. You can sometimes miscall this as a generalized discharge, but the EEG often shows maximal changes on the side that it is arising from. And then the MRI can also show you changes on one side of the brain consistent with frontal lobe focus. And so this is a young girl here you can see with asymmetric tonic seizures, and she actually had a malformation of cortical development in her left frontal region. So to conclude, Lennox-Gastaut syndrome is a severe, typically childhood onset drug-resistant epilepsy. The core features really are tonic seizures with at least one other seizure type, usually atypical absences, but many other seizure types can be seen. The EEG hallmarks are slow spike wave, and the slow spike wave can actually disappear with age, as well as generalized paroxysmal fast activity, which tends to remain with age, but can be seen only on a sleep recording. And then there is progressive intellectual disability with time. People with Lennox-Gastaut typically evolve over months to years, and they really take that time to evolve to a full clinical picture. It is not uncommon for young children with other DEEs to evolve towards Lennox-Gastaut syndrome. So there is, hopefully we can identify for some of those individuals kind of that window where we might be able to jump in and intervene if we can identify a precision therapy. Some of the core features resolve with age, and so the diagnosis, I think, can be a little bit more challenging in adults without a clear early life history. So thank you very much for listening, and happy to answer any questions.
Are there any pressing questions? We could take them now. We also have a half-hour discussion session at the end of the 4 talks. Don't see any
there
now.
are a couple questions that came from the chat, it sounds like. Do you see progressive dementia with LGS?
So I'm not sure I would call it progressive dementia, but I think, over time, so you can occasionally see some individuals who actually cognitively lose ground, which I guess you could term as dementia with more frequent seizures. I think what we more commonly see in kids with Lennox-Gastaut syndrome is they really fail to progress at what you would expect. So, early in life, you might say they have a mild degree of intellectual disability, and then they just gain skills much, much more slowly than you would expect for other children. And so over time, their degree of intellectual disability is more severe.